It's good to be back with all of you. We've entered the summer period, and at the same time, we are intensely focused on the return of our community this fall. The beginning of our return is already underway. This past weekend, we welcomed nearly 900 students to campus for our 5-week Summer Hilltop Immersion program. We're offering our most popular courses, experiential learning classes, and co-curricular activities so that students who joined our community last fall can experience campus life and some of what living in Washington, D.C. has to offer. As we move into the summer months, we're entering a new phase of the pandemic. Conditions in the United States have improved significantly. Safe and effective vaccines have had a tremendous impact on reducing the spread of the virus. Vaccines have been as effective as any of us could have hoped for 18 months ago. They've even held up so far against the emergence of new variants. As more and more people are able to be vaccinated, all of us have greater protection from the virus. With vaccines, COVID just has less chance to spread. With these positive developments in the U.S., local and national authorities are adjusting guidelines and restrictions, including here in the city of Washington. What does this mean for Georgetown? We're entering into a moment of great complexity. Vaccination is far from universal, and around the world there is an alarming lack of access to vaccines in many countries. We're entering a period of time in which many are vaccinated and many are not. We are reviewing and adjusting our public health guidelines with this in mind. To help provide some context, first on public health guidelines, I've asked our Chief Public Health Officer, Dr. Ronit Mishori, to share with us some of her reflections and insights on these changes. And then I'll invite back Dr. Jesse Goodman, who can provide some context on the current state of vaccines and what we might expect in the coming months. Let's begin with Dr. Mishori.
Ronit, thank you so much for joining us today. I've just described the critical juncture we have reached in the state of the pandemic. High rates of vaccination in the United States are resulting in a new set of conditions, and local and national authorities are adjusting the kind of restrictions that are needed and are providing new guidance on a range of issues, from mask wearing to gatherings to public schools. We too are looking at our approach. And so I'd like to focus today, if we could, on masks and the revised mask guidelines that we recently put in place. At Georgetown, only those who are unvaccinated are required to wear masks outdoors. If you are vaccinated, you can now be outside without a mask. We are still requiring masks indoors, regardless of someone's vaccination status. Could you describe some of the considerations that were important to this recent decision to adjust our mask policy?
Absolutely. I think one of the most important things to consider and constantly remind ourselves of is that when we talk about changing guidelines by the CDC or by the DC Department of Health, these, the ones that we read about in the papers, are meant for the community at large, for people in their homes and in their neighborhoods. And there are always special considerations for people in other settings. So, for example, a university is what's called a congregate setting. And a congregate setting, and I'm going to read the definition right now, is an environment where a number of people reside, meet, or gather in close proximity for either a limited or extended period of time. And that definitely defines a university such as Georgetown. So such other examples are homeless shelters, group homes, prisons, detention centers, schools, and workplaces. So as a congregate setting, our community is already at a higher risk. And we need to take that into consideration when we make our policies. So you're absolutely right. When we decided to lift the outdoor requirements for masking for vaccinated people, we took into consideration the high effectiveness of the vaccines. As we know from news reports, we have seen dramatically lowered death rates, cases, and even the transmission of infections. And we also know that outdoors, there is a lower risk of transmission, and outdoor places are generally safe. So it was almost a no-brainer to lift the outdoor mask requirement. But when it comes to the indoor requirement, and the reason it remains is because of what I just said, the congregate setting nature of the university, and the fact that indoor spaces confer a much higher risk of infection because of the nature of how the virus transmits and aerosolized transmission. And to add to that, over the summer, we know that not all of our university community, not all of our students are vaccinated. So there's a sizable population that remains unvaccinated through the summer. All of these factors together made us make that decision to take the masking limitation off on outdoors for vaccinated people, but keep it for everybody when it comes to indoor spaces.
Now, you mentioned a moment ago aerosols and the role of aerosols in spread. And I know that's connected to the indoor mask requirement. Could you take us a little bit deeper into why it was so important for us, why it is so important for us to maintain our indoor mask requirement?
Absolutely. So the virus spreads in a few ways, but in two ways primarily. And when it comes to indoor spaces, so there are small particles that are droplet size and shape, so are very small, but still sometimes even visible. And when people cough or yell or spit or sing, those droplets can fall to the ground because they're relatively heavier than the air. And so once an infected person does one of these behaviors, screaming, singing, laughing, sneezing, the particles fall to the ground and the person moves forward and they remain where they are. But we also now know that the virus spreads through aerosols. Aerosols are much, much smaller. They're not visible to the naked eye, and they remain suspended in midair. And when you're in a room when there's no ventilation, or even when there is ventilation, but you remain there for some time, for more than 15, 20, 30 minutes, those aerosolized particles remain in the air. And if they are filled with virus, if they're and you're unvaccinated, or even in some situations for people who are vaccinated, it is much easier for the virus to transmit that way.
Got it. Now, our layered public health approach means that we pay attention to many factors, not just one, such as mask wearing. There are also other guidelines that intersect with mask wearing. For example, why might someone who is vaccinated still need to wear a mask at a large outdoor gathering?
Well, we know that definitely the risk is much, much lower if you're vaccinated, but it's not zero. And so large outdoor events remain a function of the density and the size of the people who are around you. And so if you're in a packed sports arena, for example, or a concert, and people are yelling and screaming, even if you're vaccinated, you still have a risk of getting infected because of the nature of the setting. Again, a lot of these policies relate to the nature of the setting where you are, its size, whether it's indoors or outdoors. So being around unvaccinated people potentially in such settings and for a long period of time and with behaviors that are inherently higher risk, there is still a significant risk for getting infected, even if you're fully vaccinated. Of course, risks are much lower, but they're still there.
Got it. Now, while we continue the push for widespread vaccination, can you talk about some of the challenges of building a public health framework when some people are protected by vaccination and some people are not?
Yeah, so in effect, I think what is happening is there is now we're creating a two tiers by risk. So there are the people who are unvaccinated who are now belong to the high risk tier, and there are the people who are fully vaccinated who are now in the low risk tier. And by low risk and high risk, I mean risk to themselves and to transmitting the virus to others. So every policy that we have to deal with right now, we have to consider these two populations, these two tiered approaches. And that makes things a lot more complicated, but we have to be ethical and morally we have to be very cognizant of the fact that we are protecting those who are more vulnerable, whether they're more vulnerable because they're unvaccinated or they're more vulnerable because of other issues, health conditions, age, and other factors. So there's a duty for us to protect the entire population, vaccinated or not. And now people fall into these two tiers, so we have to think about both of them at all times.
When you look at the current state of the pandemic, what are the issues that you are most focused on? As we look at the improvements here in the United States, what else should we be mindful and attentive to?
First of all, I think vaccination status of our members of our population is still the number one priority because there's so much evidence that vaccines are very, very safe and so effective in cutting down the numbers of cases, of hospitalizations, of deaths. So we're still working very hard to try to get anybody and everybody vaccinated. So this is great news all around that the vaccines are very effective and safe. But there is one concern, and that is variants. And there are different variants out there, and some of them have been shown to what's called evade some of the vaccines. And there are studies that show that some of these new variants may be better at evading the vaccines and being more, not only more transmissible, more infectious, but also causing more serious disease in larger populations and larger numbers of people. So a study actually just came out the other day that the Pfizer vaccine is not as effective against the variant that originated out of India, now it's called the Delta variant. And other studies have shown that the vaccines are very effective, but not as effective if you're dealing with variants that originated perhaps in Brazil or in South Africa. Again, those are now have new names by the WHO. They're called the Gamma and the Beta variants. So those are still out there. Our population is transient. Our population in DC and at Georgetown is very international. So this is not a risk that we should, this is certainly a risk that we should pay close attention to.
Got it. Got it. Oh, Ronit, I can't thank you enough for taking this time to share your insights with us, your reflections, and for all of your exceptional service over the course of this past year. Your leadership in our community as our Chief Public Health Officer has been invaluable. And I can't thank you enough for everything that you do for our community and for sharing this time with us today.
Thank you so much. I'm so honored to work with this population and with you and with the university, and we're doing our best to keep everybody safe and healthy.
We're grateful to you. Thanks again.
As Dr. Mashori just described, the rate of vaccination within a community is shaping the kind of public health measures that can best protect a community. There are other factors as well that contribute to public health, the type of setting, the context, the activities that take place within a community. We are a residential community on our campuses here in Washington with students living in close proximity to one another. On our main campus, we're situated within a neighborhood of 15,000 residents for whom we share responsibility. For the second half of today's presentation, I've asked Dr. Jesse Goodman to share with us some information about vaccines and what we can expect in the next few months. Dr. Goodman is an attending physician and professor here at Georgetown who served for a number of years as chief scientist of the FDA, of the Food and Drug Administration, and he now leads our Center on Medical Product Access, Safety, and Stewardship here at Georgetown.
Jesse, thanks again for joining us for this conversation, and it's great to have you back. I want to start first with the protection that vaccines offer. Of the vaccines approved for use here in the United States, what do we know about how effective the vaccines are? Has our understanding of their effectiveness changed as more people have become vaccinated?
Well, in general, it's been very positive news in that the effectiveness of these vaccines in reducing the risk of getting COVID has held up to the high levels of what was seen in the clinical trials. So real world evidence, particularly from countries with widespread vaccination and good health records, that is Israel and the United Kingdom, have continued to provide us information about these vaccines' effectiveness as they've been given to millions of people. And the news is good with the RNA vaccines from Pfizer and Moderna holding up at about 90 to 95% effective in reducing the risk of disease. And less data because less widespread use, but the Johnson & Johnson vaccine, which is the other authorized vaccine in the US, efficacy seems to be about 70% for all disease and higher, 80% or so for moderate to severe disease. So, looking good. On the other hand, we are seeing variant viruses which challenge these vaccines and which mean that we need to be keeping aware of what's going on.
Let's go in a little bit deeper into the new and emerging variants of COVID-19. A new variant was discovered in India that is now referred to as the Delta variant. How will we know if the vaccines are safe against these variants? Should we expect to need booster shots of the vaccine?
Well, we're starting to see information on that variant. Again, the information from the United Kingdom has been really helpful. And that has shown that while the Pfizer vaccine, the RNA vaccine, has somewhat reduced efficacy, after 2 doses, there's still a high level of protection. But particularly during that interval between the first and second dose, that protection may be lower. And so again, the vaccine constructed against the original virus variants is not quite as effective as against the most different variants, like the one that originated in India and the South African variant, as well as one in Brazil. So, it's again positive in that there is protection and it appears to be particularly good against severe disease, but those levels of protection are somewhat less, and particularly after the first dose of the RNA vaccine. So this needs to be monitored better in the US as well, because what we need to see is our breakthrough infections that occur, are these variants represented among those breakthrough infections, and will that be a warning sign that perhaps they're beginning to escape the vaccine?
And perhaps you could go into a little bit more detail about breakthrough cases. Breakthrough cases occur when someone who is vaccinated becomes infected with COVID-19. And we know so far that these tend to be more minor cases that haven't resulted in hospitalization. But what else do we know, and what does it mean for the overall protection we have against COVID?
Well, even an incredibly effective vaccine like the 95% with the RNA vaccines, as I said, can be challenged by these variants. And even if they reduce your risk 95% against the original virus, that does mean that as more and more people are vaccinated, that 5% is a significant number still. So that 5% that would break through in the clinical trials or in the population of Israel starts to represent thousands and thousands of cases. So that's happening in this country, that's happening elsewhere. So even if your risk is tremendously reduced, and as you said, your risk of a severe outcome or death is tremendously reduced, because so many people have been vaccinated, so long as the virus is still circulating, we will see cases among vaccinated individuals. And again, that's something that needs monitoring to be sure that isn't accelerating, to be sure vaccine isn't losing effectiveness. So far, that's not happening. But people need to realize that 95% is not 100%. 95% means that a small proportion of people exposed, where the virus is still circulating, will become infected despite vaccination. As you said, the severity is generally less, but still there are people who've been completely vaccinated who have ended up in intensive care units and even died. So we really need, this is part of the reason we need to control the epidemic by getting everyone vaccinated. And also the reason there's a special challenge for our individuals who want to be vaccinated and are vaccinated, but whose immune systems don't mount a strong response to the vaccine. So we're seeing much lower protection from the vaccine, for example, in patients who've gotten organ transplants and immune systems are suppressed, or in some cancer patients if they're receiving treatment that severely suppresses their immune systems. So this is another good thing we can do when we get vaccinated, is we're protecting not only ourselves, but those who are most vulnerable among us.
I'd like to ask you one more question about the vaccine's protection. Could you talk about the FDA decision to allow children as young as 12 to receive the vaccine? And when should we expect that children below the age of 12 would have access to the vaccine? You've had a long and deep experience with the FDA. What goes into this process?
Well, you know, FDA has been trying to get the balance right between moving things along quickly because we're in a pandemic, but ensuring that the actual science is strong. And especially when it comes to children, that's critically important. You know, children generally don't have severe COVID infection. Some of them do. 1 in 1,000 or less can have this severe syndrome called MERS, or multi-system inflammatory syndrome. MIS-C, or multi-system inflammatory syndrome, that can be just terrible and heartbreaking. So we need vaccines for children, but we need to be sure they're safe. So what FDA has been doing is requiring studies in those populations, in those ages, and strong safety data from those studies, as well as data showing that the immune response is similar to that seen in adults. And Pfizer completed that study and submitted it and received authorization based on data that look very similar to what we've seen in adults. Now, I will say that children, just like younger adults compared to older adults, appear to have some of the kind of routine reactions like fever, muscle aches, et cetera, that are somewhat more frequent and severe than adults. So we're going to have to really monitor that in the studies that are going on now in the younger children. So the adolescent studies are completed, but the studies below 12 years of age and going all the way down to infants are still underway. You know, as to when we'll have data from those, I think if those studies go smoothly, they should be completed within a couple of months. And so we could look for data late summer, early fall. And if all that data are good and the vaccines look safe and effective in younger children, FDA will get it submitted sometime in the upcoming months and look at it.
There's another aspect of the licensing process. We discussed earlier this semester, there are 3 vaccines currently approved by the FDA for emergency use authorization, EUA, here in the US. And since then, 2 vaccine manufacturers have submitted additional data to the FDA to request full licensure. Could you talk about this process? How does full licensure differ from emergency use authorization? And is there a time frame in which full licensure is likely to be in place?
Right. So in a public health emergency, such as this pandemic, FDA has some flexibilities under this statute called Emergency Use Authorization, or EUA. And that allows them to look at somewhat earlier and in some cases less complete data to determine that the benefits outweigh the risks, in their opinion, of this product. In the case of the COVID vaccines, because they were being given to healthy people, because they are new technologies, FDA set a very high bar for this emergency authorization. It required studies of several thousand people. It required strong efficacy and safety data. So the clinical data that we had is very similar to what we would see for any vaccine that's approved. What's a little different here is that the length of follow-up during the pandemic for the emergency authorization was fairly short. So FDA required that the majority of patients have at least 2 months follow-up after their second dose. Whereas for approval, FDA is requiring at least 6 months follow-up. So we'll have much more complete data on efficacy over time with respect to clinical understanding of the vaccine. In addition, we'll have the additional safety monitoring that's taken place both from the patients in those trials and from the broad population safety monitoring that's been going on and that detected, for example, the rare blood clots from the J&J vaccine. So there's much more time for the data to accrue, and FDA will look at that in order for that to meet the criteria for full approval. In addition, there are certain things that in the emergency, because this vaccine was going to save lives, FDA allowed to be completed and submitted later. And these might include very detailed criteria about testing and release of specific lots of vaccines, studies that show that multiple lots of the vaccine produced have exactly the same effect in people, detailed inspections of the facilities involved in making the vaccines and their components, testing, in animals and other systems for unusual types of toxicity or toxicology. So there's quite a number of things that were probably submitted in preliminary form or where FDA said right now in the pandemic, we can wait for this complete study, but which FDA will require for licensure. So once it's licensed, it will be pretty much like any other vaccine that we have in terms of the standard it's met because of this additional follow-up and much more complete data on quality and manufacturing.
Jesse, I can't thank you enough again for taking this time to share with us. We are so grateful for your leadership in our community, the work you're doing on behalf of all of us.
And thank you again for joining us for this presentation. I look forward to being with all of you again soon. Take care of yourselves and take care of everyone around you. For every Hoya, everywhere.